Thank you, Rio. Hello, everyone. Welcome. Thank you for joining us. I'm going to share our screen here. We appreciate you all joining us today on the topic of increasing diversity in your simulation design or your simulation curriculum. I am Dr. Kimberly Whitten-Chung. My pronouns are she, hers, and hers. She, her, and hers. And I'm joined today by Dr. Adrienne Wilk.
Hello, welcome everyone. Thank you so much for logging on. We're excited to get this presentation started. As you can tell, we're talking about diversity today, and so I just want to come and just, I guess, explain a little bit. I am not an expert in this topic. I am coming to you. Kim is. She is published on this topic. I'm coming to you as somebody who's made a lot of mistakes along the way, and I want to share some of those lessons learned and lived and talk to you a little bit about my journey, and I'm excited to share that, and hopefully we can have some dialogue with you as well. If you've tuned into any of our previous presentations, you know we like a lot of back and forth and discussion. Kimberly is driving the PowerPoint today, so I will be monitoring the chat. So any questions that you have throughout the presentation, don't hesitate to throw them in the chat. I'll answer them either directly or we'll open it up to the group for discussion. So thank you for joining us.
Perfect. So very quickly, we'll get our objectives for our presentation today are, we want to explore why should we incorporate diversity into simulation. We want to discuss our opportunities to increase diversity in simulation. And of course, we're going to examine some obstacles in increasing diversity in the simulation. And to ground our conversation, we have to start with what's our lens. And so Adrienne and I are both white, obviously, cisgendered, which means we're heterosexual, women who are upstanders. And if you're not familiar with the term of upstanders, an upstander is someone who chooses to intervene, interrupt, or speak up when you see bullying or an injustice occurring. And we have no conflicts to disclose, but it is important just in case something comes up that we might specifically speak about a product. We do not intend to endorse or encourage you to purchase said product. Anything else on that, Adrienne, before I go on?
No, we're good.
All right, so to get us started, the foundation of why we need to incorporate diversity into our simulations. So on this screen, you'll notice that at the top, I have the US Census, and at the bottom, there is the presentation from Crow et al. That specifically covers the demographics of EMS. So if you notice, the US Census lists 5 independent races and origins, and the option for a 2 or more races. Also notice that in the US Census, there's not an option that specifically identifies Hispanic or Latino, Latina, or Latinx as an option. And just as a quick note, so we're all talking with the same language, I use Latino, Latina, and Latinx because Spanish is a gendered language. And this does not encompass our gender diverse community, so Latinx specifically, to encompass gender diverse. In contrast, the demographic reporting from Crow et al. Is specifically in contrast with the US Census. So despite the differences, the message is clear. The US population is increasing. Females, if you notice, are a minoritized population, yet represent 50.4% of the US population in the 2020 census. However, at the time of the Crow et al. Data, females only represented 35% of EMTs and 23% of paramedics nationwide. And this is nationwide data. This isn't data broken down state by state. So I recognize that the demographics in your areas might be slightly different or significantly different depending on where you're at. Black or African American people represent 13.6% of the US population, but only 5% of our EMTs and 3% of our Black or paramedics are Black or African American. 18.4%, which you can't see on this, but 18.4% of the US population is Hispanic or Latino, Latina, or Latinx. Only 13% of EMTs and 10% of paramedics are Hispanic. And then the final group is known as other. And I'm referring to the Crow et al. Data, which presumably encompasses the American Indian and American or Alaskan Native, which is 1.3% of the US Census, Asian, which is 6.3% of the US Census, and sorry, my lights turned off, and Native Hawaiian or other Pacific Islander, which is 0.3%. That's 8% of EMTs and 5% of paramedics collectively grouped together. So we have challenges in the reporting, right? Because our reporting does not clearly align between the US Census and then other reports that come out. And we see this across all of our demographic reports. We don't have clear delineations in reporting, even in the race or origin. And I suspect that you guys have this challenge as well when you're doing your PCR writing, where you either have to guess what a patient's race is, or perhaps you don't enter that data. And so we have really skewed data. So why does this matter? I really like this slide. I think it's my favorite one.
Well, and I would just like to say before
Yes,
we get to this
please.
part is obviously I'm an RN. I am not an EMT or a paramedic, but we have very similar difficulties. And like you had mentioned, it's all across healthcare, not just in EMS, but also in nursing. So my specialty is SIM, and that's how Kim and I kind of collaborate. So you're like, why is a nurse on this webinar? But you know, we struggle with the same things, both in our student populations. I teach for an undergraduate nursing program. So our student population is not representative of that, of similar percentages and distributions of the overall population. And our faculty representation is not as diverse as what it should be. So it's a multifaceted, multi-layered problem that we know we need to fix. And so that's why I feel passionate about it. And I'm here with Kim today. So sorry, I just want to interject that.
Oh, perfect. Thank you, Adrienne. Thank you. So the demographics matter because there's a disparity in patient care in our diverse populations, which is my chaos in this slide here. We see this in the management of pain, the administration of bystander CPR and out of hospital cardiac arrest, and in treating long-term conditions like cardiovascular disease, asthma and COPD, diabetes, hypertension, stroke, alcoholism, and most recently in COVID-19. So, like Adrienne just said, representation matters. And what we're seeing in most recent literature is patient-provider concordance, meaning that if I have an African-American provider, or Black, I have providing care to a Black or African American patient, then that increases patient satisfaction and leads to better patient experiences and improves patient outcomes. And I don't mean to indicate that all other races are not providing good patient care. However, what we do see, particularly if you read these headlines here, it's not headlines, literature, the titles of these journal articles, is that there is disparity in care. And so this provides the foundation for our talk today, because simulation gives us an opportunity to address these disparities in our curriculum. Scroll down. So as we go through, I've got a couple bullet points here. Two of them specifically speak to the EMS agenda 2050, and then the NAEMSE position statement. But if we speak about, so in 1998, Leninger posited the cultural humility theory, which supports DEI, diversity, equity, and inclusion in all aspects of healthcare, which includes student learning, faculty teaching, and provider and patient care outcomes. And cultural humility replace cultural competence, because cultural competence indicates that there's an end point in our learning. But cultural humility rather is the idea that we are consistently and continuously learning about each other and other cultures, and the idea that it's a lifelong learning event. And so cultural humility has three core principles: lifelong learning and critical self-reflection, recognition of and compensation for power imbalances in the provider and patient relationship, and institutional accountability to students, staff, faculty, patients, and communities. And so as we develop our curriculum in simulation, and quite frankly, everything, it's important for us to consider that lens. And again, going back to my lens, and quite frankly, my lens is different than Adrienne's lens, right? My experience is different than Adrienne's experience. And so it's necessary for us as educators to take a step back and go, okay, how do I approach this teaching? And Adrienne and I had a really good conversation, and we can get into it later, but we actually have, in fact, 30 states right now that have very specific, and I don't remember the name of it, Adrienne. Adrienne's going to have to speak to this.
Sure. Yes. Divisive concept legislation. I currently work for a state institution in a state that has divisive concept legislation. And so when we talk about curricular development and some of the hurdles that I have to overcome in order to meet the learning outcomes of my program that I teach for, as well as best practices and meeting the needs of the community in which we serve, there's some legislative hurdles that I have to overcome, and some nuances and things that I have to deal with that are maybe unique to certain states rather than others. So yeah, we're going to talk about that and how, if you are in a similar situation, how to maybe go about that as we move forward.
Thank you. So as in the definition of diverse characteristics, I just have a list here for you. And the idea that, and I imagine like most of this is perhaps not surprising or unusual to you, but certainly something that we need to consider as we go through and develop the curriculum. And the reason that this list is important is that as we write our simulation curriculum, and we'll get into it in a little bit, but as I look at this list, if I'm not writing a white, cisgendered, middle-aged woman, I probably need to refer to a subject matter expert. In addition to the fact that I refer to a subject matter expert on different content of trauma, medical, I also need to refer to a subject matter expert in these diverse characteristics. And so we'll talk a little bit in a second about like why that's important.
Well, and I would say when I got started with this and really started to self-reflect and to humble myself to think, oh, wow, I'm probably not encompassing as many different topics or concepts as what I should. When I reflected on this, in my mind, diversity was basically ethnicity and maybe a little bit about religion or sexual orientation. I never thought of veteran status as a diversity concept or a characteristic. So I think maybe some of this on here, even just the ableness, I'm thinking in my own simulation curriculum, do I have any diversity in there? I don't know that I do. So I think it's the biggest takeaway from this, hopefully, is just that self-reflection piece, that humility to know that this is an ever evolving topic and we can always do better and have that continuous cycle of how am I doing? Oh, there's some area for opportunity. I can move forward. Because even just today reading this, I'm like, I may need to, with the ableness, I may need to add a little bit of that. Mm-hmm.
Right. And the idea that ableness is not always visible, right? Like there's varying levels of ableness. And particularly with that one, we can certainly add things that cases where, we think of ableness as like, do they use a wheelchair? Do they use a walker? Do they use a cane? But then you evaluate all of these other areas of ableness, such as a fibromyalgia patient. Because I just did something that we're going to talk about later, and the patient first conversation, right? So it's not a fibromyalgia patient. It should be a patient that has fibromyalgia. Our language is incredibly important. And so that's, and so the patient that experiences fibromyalgia is not always in the situation where they're inhibited by that condition. However, if they're in a flare, then they certainly are in or may be experiencing inhibition or an inability to do certain things because of the condition. And so, however, I can read a website about it, a journal article about it, and have a cognitive understanding of what's going on. However, I do not have the patient's perspective. And that's what we miss when we just read the, website about fibromyalgia. And that's what we need to pull into these simulation designs.
And when you're looking at how do I get started, so yeah, just one second. If you're looking at how do I get started, because it is overwhelming. Like if you're like me, the first time that I really sat back and looked, kind of put all my sims out on a spreadsheet and was like, wow, I really need to do some work here. It's kind of twofold. So the first process, or the first part of the process, is do I have patients or scenarios or actors that represent all of these different diverse characteristics, because representation matters. So we want those represented. But then the second piece of it, because just simply having a diverse character in your simulation portfolio isn't enough. We want to actually teach our students or our providers how to provide culturally sensitive or, cultural humility, like care. So then we need to create scenarios that actually have objectives that are matched with that diverse component, so that students are actually learning about the diversity that you have implemented into that simulation. So to get started, you can go, oh, my lights just went off too. So to get started, you can just try to implement different diverse characters, but then after you have a certain comfort level with that, then you can move on to creating actual scenario objectives to start talking about what does that diversity mean for this patient and for their healthcare.
Yes, thank you. Super important. It's a multifaceted approach that doesn't just involve saying, this my patient is, you know, diverse,
Right.
because that doesn't meet the need.
Right.
And so, in fact, I had, when we speak about the idea that, you know, the mistakes that we made, multiple mistakes along the way, right? And so I had, I've used case studies in my classes for years, which isn't exactly simulation, but so years ago, I had a case study that involved a older Hispanic female that I had gotten from a textbook, actually. And so again, this goes back to the idea that you can't just draw from something from literature. And I had described the environment and one of my Hispanic students in class came and pointed out an error to me in the way that the scene was presented. And I had no idea, because, you know, I just drew it from the literature. I hadn't actually spoken to someone about it, which, oh my gosh, these lights are killing me. You're doing great with the lights today, Adrienne. And so it highlights the very importance of actually speaking to someone from the culture. And so and the need to, because what we present brings to the students of, this is the culture, and that doesn't work. So as educators, we are in a unique position, and I'm going to speak globally, and then we're going to talk about divisive concepts. So as a generality, we are in a unique position to be able to be upstanders and intervene with racism and bias. And not only are we in the unique position, I believe we have the obligation to do so. However, as educators, we have very little education on anti-racism, anti-bias, and inclusive learning. And I can very comfortably say this because we do a lot of research on this with NAEMSE, which is another group that I'm with. And so, like we said previously, as upstanders, when you see something, you say something. And initially, that can be really hard to do because it makes you feel uncomfortable. But the more that you do it, the more that, number one, people stop doing it. But number two, the more that you feel empowered to say, this is not okay. This is not what we do. This is not how we behave. And that is not only does that change the culture, right? Because I believe that we start to change culture in EMS in the classroom. But it also, it lays that foundation of, this is the way we behave, and you model that behavior for your students, and then that your students go out and model that behavior in the field. So, however, as I said, we have 30 states with some sort of divisive concepts legislation, either passed or in process. And so, so now let's have a conversation about that.
Sure. So like I mentioned, I can't, with the way that the Zoom is set up, I can't see if anybody else is kind of shaking their head if they're also in a state that has this divisive concepts legislation. But what it basically means is I work for a state-funded university. And with that, the state where I work, their government has made legislation, and it's known as the divisive concept legislation, that restricts what I can and cannot say in the classroom. And so for certain other disciplines, that may be okay, that may not affect the outcome of the student's education. But for those of us in healthcare, we know that healthcare disparities exist. We know that there are vulnerable populations. That's something that has been discussed. It's evidence-based, and we want to address that in our curriculum. The trouble, and I have it pulled up here, I'm just going to read a few things. So part of the legislation says that I cannot state that any individual race is inherently privileged. I cannot use the term white privilege. I can't talk about any certain race or ethnicity bearing the responsibility for actions committed in the past by other members of the same sex or race. There's a lot of, I could go on, but you kind of get the gist of the things that I am not allowed to say. So when I talk about healthcare disparities and vulnerable populations, I am not allowed to talk about systemic racism. And we know that systemic racism is a huge factor that plays into the healthcare disparities that still exist within our country today and across the world. So it's very hard for us to do that. And so the way that we've kind of worked around this legislation is we do just that. We talk about healthcare disparities, and we talk about those special vulnerable populations and what sorts of things might get into that, but we have to be very careful about our language. We do have a university-sponsored divisive concepts legislation paragraph that we all put into our course syllabi to say that, hey, we're going to talk about these topics. And if at any point this makes you feel uncomfortable, secretly I'm thinking, good, discomfort is where growth occurs. So let's have these conversations, let's have this dialogue. But if at any point a student were to feel that I was trying to influence their political or moral beliefs, there is a reporting process as part of that legislation that my university's funding by the state could be in danger if they find that I was somehow violating this divisive concepts legislation. And so I don't know if any of you else out there have similar laws, want to talk about it later, but it is it's a hurdle, but it's not stopping us from attempting to meet the needs of our patient population here within our community and abroad.
Excellent. Thank you, Adrienne. And one of the things that Adrienne and I had a conversation about was, one, depending on where you're teaching, obviously, divisive concepts legislation or something like it would certainly impact you.
Mm-hmm.
But two, I don't know how that would impact any like continuing education. And so that's certainly a consideration for anyone in education. And so definitely I would encourage you all to make sure you know your laws, because I don't want anybody to get in trouble. So while
they removed our DEI annual training as a part of that law, the DEI training that we were all required to undergo has gone away. So again, the removing of any type of formal education, even to faculty who are trying to teach these concepts.
Wow. Mm-hmm. Wow. I mean, that's and we're seeing it happen in multiple states. And so that's, I have not looked at the impact on EMS agencies. And so
it's interesting.
It is interesting. it presents a challenge. So, yes. However, it does not, I believe, stop the necessity because we treat patients. And I firmly believe that our responsibility, both as educators and as providers, is first, as educators, we meet the students where they're at. It is not the student's responsibility to meet us where we are. And as providers, we have the responsibility to meet the patients where they are. And we need to appropriately educate our students to be able to perform that function. They need to be able to meet the patients where the patients are at. The patients have no obligation to meet us as providers where we are. So we need to be able to adapt our communication to our patients. And so I think that, and again, simulation brings us to that. So we defining simulation specifically, because I recognize that simulation itself has multiple, when we say simulation, it's very likely that everybody in the room has kind of a different thought of that. So we go back to the Healthcare Simulation Dictionary, second edition, for the definition of simulation. And so simulation is a technique that creates a situation or environment to allow persons to experience a representation of a real event for the purpose of practice, learning, evaluation, testing, or to gain understanding of systems or human interactions. And just as a side note, the Institute of Medicine since 2003 has supported simulation as cross-cultural education. So in our simulations, oh, I'll go down, sorry, I got to go to the next slide. In our simulations, the scenarios are created to present students with an environment that places them into the situation that allows the students to suspend disbelief. But this relies often on the educator that's not from the racial, ethnic, or social background, so an outsider, of the diverse patient that they intend to represent and evaluate, which is what we were talking about before, right? Like Adrienne and I cannot present a situation that, such as a Muslim woman from Pakistan. And I use that example because I have a friend that is a Muslim woman from Pakistan. So if Adrienne and I are presenting this case, a Muslim woman from Pakistan with abdominal pain, we should not sit down and write this scenario as two white women. That just doesn't make sense. So what happens when we do that is that we are writing this situation as if we are the normal and our patient with a diverse background is different. And that concept is called othering. And so what we do in that situation is we create a stereotype and we stigmatize a culture. And then we put we put our students into that scenario that we've developed, that simulation scenario that we've developed. And any student that relates to that developed patient now feels stigmatized and othered. And so there's repercussions as a result of that. And the other students that feel like they're part of the normal now carries that stereotype into their practice. And that's what we want to avoid. And so that's where the spoiled identity comes from. The student who relates to our othered patient has a spoiled identity. There's significant consequences as a result of the simulation design when we don't incorporate someone that is actually part of the culture that we're trying to develop.
And I just want to add a point to be clear that, yes, absolutely, you should have a content expert there. But you are also responsible for coming to the table for that collaboration, having done your homework. It is not 100% the responsibility of your collaborator, your content expert, to teach you all the things. So I think that's, especially over these last few years, as more folks are becoming upstanders and are self-reflecting and they're wanting to learn, they're going to other individuals and say, oh, I didn't know, tell me what I need to know, tell me what I can do. And it's really up to us to do our homework, to reach out and to figure out some of it on our own and try to educate ourselves before going to those other individuals and saying, okay, this might be what I understand. Is this your perspective? Is this your experience? Not just expecting 100% of the work to be on them. We have to be a partner in this, not just the receiver of the knowledge, but a partner in it.
That's so important, Adrienne. Thank you. And the other thing is, since as Adrienne says that, it occurred to me that it's really important to reinforce that the one person we go to is not responsible for representing an entire culture.
Right.
Right? Like, my perspective does not represent all white women in the United States. Mm-hmm. So that's really important for us to keep in mind as well. So as we go through the development, we're about to get into the implementation of the scenario. So just some groundwork for this. Obviously, I say obviously, but it's important to hit on, right? Our patients that we develop are portrayed sensitively, accurately, that's not a word, accurately, respectfully, and realistically. And our communication is respectful and inclusive, and we encourage equitable participation. We want to create the scenarios that we expose the learners to our marginalized patients within the healthcare system. And then finally, that person first language, which you heard me use incorrectly earlier in the presentation. And so this is where we have not homeless patients, but patients experiencing homelessness, not a diabetic patient, but a patient with diabetes. And so person first. So that we humanize our patients.
And I told you, I'll tell you about my lessons learned. So one of an ex-student actually brought up the fact that I thought I was doing good. I went out and I bought the tattoo sleeves to put on the mannequins, just to represent that I, as a person with tattoos, well, you know, a lot of our students, a lot of our patients have tattoos. And so I thought I was doing a great job by going out and purchasing tattoo sleeves, putting them on the mannequins, until a student brought it to my attention, to another faculty, that the only patients that I was doing that to were the ones with substance abuse histories or a little bit rougher lifestyle. And it dawned on me, wow, as again, someone with tattoos, why wouldn't I put the tattoo arms on patients without those types of backgrounds and histories? And so even in your attempts to do something to show diversity, to show just differences and be more encompassing, you realize that your bias, even your self-bias sometimes is showing. And even just showing the veteran, and I'm thinking the only veteran scenario I've ever written, he was an alcoholic. So you're learning as you're going through, and that's okay, as long as you're always trying to do better, be better, and go back and revamp and look at, okay, I tried, I missed the mark a little bit, let's tweak things and let's keep moving. So again, I always just like to share my successes and my failures, or my not quite full successes, so that people can learn from that.
Yeah, thank you. And that's, I think that's really powerful, right? Like it goes back to the cultural humility, and it's a lifelong learning process. It takes critical reflection, and we have to be humble in our approach. Yeah. And so it's incredibly important. So, Adrienne, will you walk us through
Sure.
the simulation itself, and then I will just kind of add in here.
Okay, so there's definitely a lot of different standards. And if you've seen our previous work, you know that we talk a lot about simulation and best practices and how to do sim that is not traumatizing to our learners. And one of the big things we talk about is psychological safety. So any simulation, it doesn't matter what your scenario holds, what the punchline or objectives are, you should have some form of a discussion about psychological safety before you begin. That is of utmost importance if you have any type of potential objective, either related to a diverse concept or characteristic that you might feel would elicit a strong emotional response from your learners. So it should be a blanket thing that you do before every simulation day, but particularly those, let your students know this may be a tough topic or a concept that hits close to home, and we never want to traumatize our learners in sim. If they're feeling those strong emotions and they don't feel like they can move forward in this scenario, they need to reach out and let their facilitator know, ideally ahead of time. But if not, if it's something that creeps up during the sim, they need to feel comfortable enough to tell the facilitator. Ideally, their pre-work, they're going to have some sort of pre-simulation day homework, quiz, prep assignment, so that they are coming into the simulation informed. We never, even in a field where you have to make quick decisions and you don't have any pre-knowledge about your patient, we still want to give our learners an opportunity to come in prepared to be successful in the simulation. They're going to mess up, they're going to make mistakes anyway, even if you give them the recipe for success. But this is of particular importance. If your learners are not coming in with any knowledge about a particular diverse characteristic that they are going to experience in that simulation, you want to give them the opportunity to prepare and come in knowledgeable for that simulation experience. That differs a little bit from the pre-brief. The pre-brief occurs on the simulation day. So remind them of those objectives, remind them about the psychological safety clause or statements that you have, because again, we don't want to traumatize them and we want them to be oriented and prepared.
Oh, sorry. I was going to say real quick on the pre-brief, specific to cultural humility, Ferranda et al. Has a GRAST model on for pre-briefing for cultural humility, which is ground rules, establishing the ground rules, acknowledging that the simulation may address sensitive material, again, psychological safety, and then define concepts that relate to the cultural humility that underpin the simulation.
Absolutely. And the facilitated experience. So I don't know about your programs, but in my programs, it's our clinical instructors who are bringing the student groups in out of the hospital, and they're facilitating the simulation and they're debriefing the simulation. So you have to make sure that not only have you adequately prepared your learners, but are your facilitators and your debriefers, those who are going to be navigating your learners through this experience, are they prepared? Are they comfortable? They may not be comfortable. So make sure that everybody is prepared and comfortable, not just the learners. But like we've already talked about, using the sensitive language, patient first language, making sure that you are not stereotyping or placing everybody under the same umbrella. And that's hard sometimes when you've not had that self-reflective lens, or you don't intend to or mean to. And honestly, a lot of these things are evolving almost on a daily basis sometimes. And so you want to be respectful of your student population, your learners. And so just making sure that everybody follows that, what we call the basic assumption. We always start off with the students. I said it this morning when I kicked off sim. We know you're smart, intelligent, capable, and you care about doing your best. And we ask that you assume the same of us as your educators, your facilitators, your debriefers. We're trying our hardest, and if something goes haywire, know that we want the best for you and we care, and we will assume the same. So as long as those ground rules are established at the beginning of simulation and everybody feels psychologically safe, good conversation will ensue.
Adrienne, I do have a question on that. When you guys are facilitating, particularly with diverse situation or simulations, scenarios, how do you get that good, accurate portrayal?
How do we get it?
Options there? Yeah.
So, I mean, there's a lot of different research out there that, I mean, you could look. There are a lot of different areas that you can even just purchase scenarios that are already written, already valid, reliable, content experts that have used them. You can go from your different equipment vendors. A lot of those have scenarios pre-written, obviously outside of just, hey, my neighbor here is a different whatever than me. Let me knock on their door and see what they say. There's a lot of different simulation collaboratives or consortiums that are out there. There's listservs, blogs. There's all sorts of resources. I volunteer a lot of my time with NAEMSE and SSH, so the Society for Simulation Healthcare. So utilize those resources that come along with those various different memberships, and don't feel like you have to create everything from scratch when, like Kim said, there's probably things out there already that it may not be exactly what you want, but the character may be the character that you are looking for. You just might need to change a specific diagnosis or treatment or that sort of thing to fit your educational needs for your outcomes for the students, but don't feel like you always have to create from scratch.
And then how about once you've got the scenario, how do you implement it into your simulation? So
Sure.
like what's my best practices there?
Sure. So ideally you are pilot testing. And so before you actually put it out in front of your learners for real for the first time, ideally you're pilot testing that scenario with a similar group to that in which you will run it. So if you can pilot test it ahead of time, it's amazing the things that you overlook or you don't pick out in the planning and the writing and the implementation phase. So ideally, you're having other eyes lay on that scenario before you implement it. And then ideally, you are pilot testing it. No matter what, you should have some form of evaluation pre-planned before you run the scenario for the first time. That way you can get feedback not only from the learners about what was good, did this help meet your outcomes, was it facilitated and debriefed well, but also an after action report for your facilitators, if you have sim techs or debriefers, whoever else was on this side of the scenario, a little after action report from them that says what worked, what didn't work, what needs tweaked for the next time. So ideally, you are prepping it and having as many people look over it as you can before you pilot test, and then when you implement it, you have a really strong source of evaluation data to look and revamp for the next time if necessary.
Excellent, thank you. And then what do you think about using how about our options with like mannequins, masks, skins, and standardized patients?
Sure. So there are a lot more options now to represent diversity in mannequins. And so, it's important. We don't want to have a Black patient when we only have a white mannequin, right? So ideally, when you are looking at the equipment that you have, as you are purchasing new equipment, you are thinking about skin tone, you are thinking about gender, and you are thinking about flexibility in that equipment. She mentions skins or overlays. A lot of different companies out there now have mannequin overlays or masks, essentially, that can be placed on the various vendors' equipment to show different ages, ethnicities, and it's a really great, much more cost-friendly way than having this entire robust repository of mannequins. Sometimes those overlays and skins are a more cost-effective way to represent diversity within your equipment. And she mentioned standardized patients or standardized actors as well. If you are in a larger program that employs or has volunteer actors that portray the patients in these scenarios, think about diversifying your standardized patient pool as well, not just in gender, ethnicity, but also some of the backgrounds that they bring in with them, their life experiences. It really can add to your simulation curriculum and the learning that will occur.
Excellent. Thank you so much.
Sure.
And then how about debriefing?
So in terms of specifically which piece?
how do we debrief? What do we do with debriefing? Why is debriefing important?
So debriefing is where all the learning happens. And so I would put a plug in again. Kim and I have done lots of different webinars on debriefing specifically, but the simulation, when they're actually going through the scenario and doing the tasks, that's not where all the learning occurs. The learning occurs in the debrief. And so typically we recommend make sure you put a good amount of time in there. It used to be, we'd say at least twice as long as the simulation itself, but that's where you go through the whys behind everything. It's not adequate to just do the quick down and dirty, what went well, what didn't go well, 1, 2, 3, break. But to talk about, well, why did you choose to do that action that resulted in a good outcome? Why did you choose, or tell me what informed your choice to do blah, 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 that maybe wouldn't have led to a good outcome. And so ideally you're asking those why questions equal amount for what they did right and what they did wrong. And we tend to sometimes focus on just on the parts that were wrong. But what we commonly find is if we ask the whys about what went right as well, we found out that they got lucky, or they made an assumption that may not apply the next time they go to apply it. It may not work. That same thought process that they had, it may not be applicable to the next patient. And so the debrief is very important in simulation.
Excellent, thank you. And Ferranda also has debriefing for cultural humility, and it's not as necessarily structured as some of the other theoretical debriefing methods, but it is some debriefing questions that you can ask in that situation, or if you're using that model.
We have about 3 minutes before we have to open up for questions.
Excellent, perfect. So outcomes, just so you see, I've got just some points there, but we have very little information, very little research is published on incorporating the diversity into simulation, and even less looks at long-term effects. So what we do know is that incorporating diversity into your simulation results in a change of attitudes. However, what we also know is that that impact is not long-lasting. So what we need to do is continue to have this. And the reality of it is that it shouldn't be like this is a thing that I'm doing. We serve diverse patients. We are a diverse population. So this should just be normal. Not a single one of us is a plastic yellow mannequin. And so our simulations should not be plastic yellow mannequin. It should be diversity, reflecting our rich histories, the fact that we're individuals, and go from there. So the challenges that we've kind of talked throughout, but simulation design itself takes time, including standardized patients and getting all of this history and background. That takes time. If we're incorporating standardized patients, getting the right standardized patients takes time, and makes sure that we are not stereotyping or stigmatizing a culture is incredibly important. Adrienne, what you want to add to our challenges?
Well, I mean, I already talked a little bit about divisive concepts, but I look at it as opportunity. I think absolutely. The self-reflection piece, the first time you eat that piece of humble pie, like, oh, I thought I was doing good and I really have some room. Don't think of it as this insurmountable thing. I think a lot of grace is given when folks see that you're trying, even if you miss the mark. And so I think, if anything, that's just my little point, is just try. Any improvement, any forward momentum is good. So we did have a really good question in the chat for you, Kim. Hopefully here we just reviewed our objectives. If you feel like there's certain things that maybe we didn't get to, please let us know. And I know her next slide too, she has our email address and questions. So
resources, lots of
yep, lots of them.
Share this out. and some
So
report.
the question in the chat was, when documenting on a patient chart and the patient refers to a male, but is biologically born a woman, how do you document properly that will help the provider diagnose correctly? For example, they had a male who was pregnant and they wanted to know how to document so that the provider would know to order an HCG.
Right, right. And thank you, Celine, for asking that. And I did answer Celine directly, but
you did. Okay, sorry.
Important. No. It's such an important topic for us to talk about. And so, first, I would say that the patient, literature suggests, I wrote literate, sorry, literature suggests that we should use patient's preferred pronouns. And so unless your agency has a policy that states otherwise. Second, in your documentation, you will say that I have a pregnant patient that is transitioned or transitioning female to male. And when in doubt, you ask your patient, right? We approach the patient with compassion and curiosity and say, you know, what is your preferred pronoun? Are you transitioning? Are you transitioned? And how do you describe this? Because the reality of it is, it goes back to the idea that we don't have training, right? Not most, I don't want to say not a single one of us, but the predominance of not just EMS, but healthcare has not received not only adequate, but any training in this realm. And so any situation like that, you ask the patient. So, and Richard, you've had your hand up the whole time, and I apologize for that. Did you have a question that you wanted to ask? Any other questions? Thanks, Rio. Excellent. Well, like Adrienne said, there's our email addresses. We are always happy to have continue the conversation, have further conversation. Anything you need.
Yes, absolutely. And you may feel more comfortable offline asking. So yes, I would highly encourage you. Please reach out. We are happy to help in any way possible.
All right. Thank you both so much for presenting on such an important topic today. I love having you both here for a webinar. This was great. So thank you again. Everybody, I will be sure to include their follow-up, their contact information in tomorrow's follow-up email, as well as the recording of the webinar. And in case you missed it, the link to obtain your CEU. All right. So on that note, we will close this down, and I hope everybody has a great rest of your day. Thank you.
Thank you.
Bye, everyone.